So we'll just be cruisy. Oh, that's working now. Great. Oh, none of that was recorded. Awesome. Okay. So we're going to start with pneumonia. Basically, it's an inflammatory condition of the lung. Generally, it affects the air sacs, but it can affect the bronchus, as we'll look at as well. Caused primarily by viruses or bacteria. There are a number of risk factors. These include cystic fibrosis, COPD, smoking, asthma, anything that kind of affects your ability to evacuate the air sacs to have a really good solid cough. And obviously if that mucociliary escalator is affected as well, then you're not going to be able to bring up the pathogen, so it's going to sit there and start to grow. So essentially we inhale contaminated airborne droplets, so someone will cough or sneeze in your face, and these will contain little microbes or viruses that will invade the cells. The bacteria will invade the instance tissue between the cells, while the viruses will invade cells themselves. It's predominantly lung parenchyma that's involved. We do see some of the stroma, but as I said, it's the airways and the air sacs that are primarily involved. We do see two different morphological patterns. If it's a virus, then we generally see mononuclear cells, and if it's a bacteria, then we see the full-blown inflammatory response that we looked at last week. Both of these morphological patterns, however, follow that pathway that we looked at last week, and in fact all of the case studies we'll look at today has that pathogenesis of inflammation, that pathway underlying these case studies. With bacteria, you do see a lot more exudate as well, so you start to see edemic fluids building up both in the stromal tissue but also within the air sacs, predominantly within the air sacs. So you start to see consolidation on the x-rays. By consolidation we just mean, rather than being that nice spongy tissue, it's basically just a slab of cheese, watery cheese. So pneumonia can be broken down into three types. I've only touched on two here, one being lobar pneumonia, the other one bronchopneumonia, and then you can have stromal pneumonia, which is where the inflammatory response is localized to the stromal components and you don't see that build-up of inflammatory cells and exudate within the airways. But we'll look at lobar and broncho. So lobar is generally caused by Streptococcus pneumoniae or a Klebsiella, and it will involve a large portion of the lung. It can either be confined to one lung or it can be bilateral, not often bilateral, but it can be bilateral. And it will typically affect young, healthy adults. So it's a primary infection. You've been exposed to this pathogen and it's kicked off the immune response. Bronchopneumonia is caused by a much wider variety of organisms, can be viral as well. Generally you'll start with an infected bronchi and you'll see that lumen start to become inflamed, you'll see exudate within the lumen, and then the inflammatory cells will start to radiate out into the surrounding parenchyma, and it can become lobular, so you'll see patches of it, and it can progress onto full-blown lobar pneumonia as well. This tends to affect people in their extremes of life, so the really young. My daughter just had this, and thanks to her coughing in my face now I've got it as well, or the elderly people. You can also see it in HIV positive, anyone that's immunosuppressed. We would more term this as secondary pneumonia because generally there's an underlying condition, or a snotty little brat. Right, so this is our first case study. This patient was 30, should I say was? What happened? Was/is a 34-year-old male. No, was because they've moved on with their life now anyway. 34-year-old male, admitted to hospital, severely ill, mentally confused, hypertensive, and they had a recent respiratory tract infection with vomiting. On x-ray there was consolidation in the lung and they ended up removing a section. The pathologist's description of that was the specimen consists of a slice of the left lung, as you can see on the left image there. The upper lobe showing the diffuse consolidation. So if you look down here, you can see it's more spongy in appearance. You can see the small airways and obviously not macroscopically, but even the open air sacs give it that spongy appearance, whereas here you've got more dense tissue. The underlying pulmonary architecture can still be made out, so you'll see that on the next slide. So this is obviously under the microscope stained with a H&E, and you can still see the air sacs there. There is some fibrosis within the air sacs, and they are distended from edemic fluids as well, as you would see with an inflammatory response. But the marked response here is the inflammatory cell infiltrate and exudate within the air spaces themselves. So on microscopic examination, normal lung architecture was seen. The alveoli are distended with an inflammatory cell infiltrate, and these are predominantly neutrophils, which you'll recognise under a higher power. What we see edema fluid within the supporting stroma, but predominantly we see it within the air sacs mixed with fibrin as well. You have to remember, this being acute inflammation, despite how this looks, if the inflammatory response clears out the pathogen, this will actually go back to a normal lung architecture. And it will be those macrophages that come in and mop all that up. So this is at a higher power, so you can start to make out individual cells with multiple nuclei. So these are our polymorphs, our neutrophils. This is another patient. They presented with a bronchopneumonia, and you can see the difference here in as much as it's the bronchus itself that's primarily involved. We see that the lumen is filled with that inflammatory cell infiltrate and exudate, and it's radiating out from there. So around the periphery we've still got normal lung architecture. The slides that you have in the lab as well, I will say, my demo slides are larger pieces of tissue, whereas you've got much smaller sections of tissue, so you might not see this surrounding normal architecture. I don't want you to freak out too much, because obviously your case studies and your slides are labelled, and if there's no architecture on them that's recognisable for normal tissue, then in an exam environment I will tell you, no, this was taken from the lung, for instance, because we don't often sample things in the lab with no idea which organ they're coming from. You know, it's fairly poor practice just to rip out pieces of tissue and not label them. So if there's no discernible normal architecture, I will tell you where it's from. We move on now to gastric ulcers. Now, I talked to one of the prac groups a little bit about these. Essentially, an ulcer will occur when there's damage to the epithelium. So an ulcer is removal of that epithelium. But in the stomach, we're talking more about an upset between the mucus and stomach acid equilibrium. So the mucus in the bottom of the gastric pits is there to protect that epithelium from the stomach juices, which can actually damage them. So if we disrupt that mucus production, either through non-steroidal anti-inflammatories or Helicobacter pylori, smoking is another one, alcohol, we can actually start to see hydrogen ions start to diffuse back across the epithelium, and then this will lead to either apoptosis or damage of that epithelium, and then it becomes more susceptible to the stomach acids. Then the stomach acids come in and start to digest your epithelium, which, yeah, not much fun. So obviously when you eat, your stomach juices build up, and so that's when you're more likely to see a bleed and more likely to have acute pain. I talk a lot more about Helicobacter pylori in week 7. So week 7, just on a brief aside, there's no prac and there's no tute. There is an uploaded lecture, which is non-examinable. I think I said that at the beginning. But I would give it a watch. It's only about half an hour, but we just cover a couple of infective agents and what we see histologically. But I've given you guys week 7 sort of free, because the week after is your mid-semester, and then the week after that is your essay, your abstract due. But moving on. So we've got a 68-year-old lady. She had a partial gastrectomy. Basically, she had chronic peptic ulcers and they wanted to cut them out. She presented with intermittent burning and epigastric pain shortly after meals, and the pathologist described the specimen as an irregular portion of gastric wall. The gastric ulcer, which is this area here, is ovoid and deeply penetrating. So those of you who have seen the gastric ulcer slide, as you'll see here, you'll actually see that that ulcer is penetrating right the way down into the muscle coat itself. There was necrotic debris covering the base So this is a very grainy image, granted, but this is your gastric pits with your epithelium. You've got your muscularis mucosa moving through, and then your muscle coat through here, and you can see that you've lost all of the pits and even some of the muscle coat. So, microscopic examination revealed a non-specific inflammatory response, predominantly neutrophils again present, so these are our inflammatory cells. The ulcer extends the full thickness of the mucosa and into the muscle coat, as I've previously stated, and that ulcer was covered by a slough of necrotizing cells and exudate. So these are cells that are dying, mixed in with that fibrin and some edemic fluid. There was also some bleeding hemorrhage out onto this ulcerated surface as well. And you can see beneath the area of ulceration we're starting to get granulation tissue. So we'll look at this with fibrosis, but essentially the body's trying to repair bottom up, so you're starting to see some collagen fibrin deposits, and there's increased vasculature there as well. It's all starting to organise itself. But obviously if ulceration continues down into those blood vessels, then you're going to start bleeding into the stomach. So that was quite unpleasant for that poor lady. And this is something that we see quite regularly in terms of samples sent into the lab. Generally there'll be a biopsy rather than a whole portion of stomach removed, but quite a common occurrence for us, as is appendicitis. So appendicitis is the end result of primary obstruction of the appendix, and these obstructions can be anything from a foreign body to trauma. There's a lymph node that sits at the top of the appendix. If that becomes swollen, that can occlude the lumen, and most commonly a fecalith. So a fecalith is basically a somewhat dehydrated, impacted fecal stone, essentially, and they can make their way down into the appendix and occlude the lumen. The weirdest thing I've seen is a nail, as in, like, what's that, a 2-inch nail. I've got no idea how they swallowed it. I've got no idea how it ended up there. But we're trying to cut through this appendix, and we're like, there is something seriously not right with this. So we thought, oh, bugger it. We've got friends up at X-ray, send it in, comes back perfect X-ray of a nail. Go figure. You've had your parents yell at you, don't bite your nails. Well, there you go. So we get obstruction of the lumen. The appendix begins to fill with mucus because it is producing mucus, and it begins to swell. The increased pressure then occludes the small vessels, so we're starting to see decreased drainage, and we start to see stasis of the lymph, of the blood, and obviously of any feces, mucus, etc. that's trapped within the appendix. Spontaneous recovery is very rare, so this is often a trip to ER. And it used to be that if you're going to Antarctica, you have to have your appendix removed prophylactically. Now it's only the chief surgeon that has to have that done, because if you hit with appendicitis while you're down there, you're killed by something that would take, half an hour to whip out. So there you go. So as you're starting to see this swelling take place, you start to see inflammation. The bacteria within the mucus, obviously this is not an aseptic environment, it's an environment involving normal gut flora and feces, so these bacteria begin to proliferate as well, and they can break out through the walls, and then obviously you trigger a massive acute inflammation. The end result of this swelling, this stagnation, this mucus production and bacterial growth is an appendiceal rupture, a burst appendix. So this will cause peritonitis because you've got all of that contaminated material then flooding into the peritoneal cavity, which can lead to sepsis and eventually, well, and quite quickly, a very painful death. So our case study, a 16-year-old man, he presented to the emergency room with right lower quadrant abdominal pain, vomiting and leukocytosis. An emergency appendectomy was performed. On that note, I was talking to someone who works down there not that long ago, and they were saying that if they cut you open to perform, and you could correct me on this if it's wrong, if they cut you open to perform an appendectomy, they have to follow through with it, and I was told that's because if you present with signs of acute inflammation of the appendix, they'll whip up your top, see if you've got a scar. If you've got a scar, then they'll remove that from the differential diagnosis at that time. So have you heard anything similar to that? Or? If they cut you open and then when they cut you open it's not inflamed, they still go ahead and remove it.
It's not a hard and fast rule, but
Right. Yeah. Okay.
I just want to rule it out.
Yeah. Well, we'll say it's true because it sounds cool. So the specimen consists of an 8 centimetre long appendix with the attached mesothelial, the mesoappendix, so that fat. The serosal surface shows multiple irregular areas of congestion. So when we're talking about congestion, we're talking about bleeding essentially within the tissue, and there's some hemorrhage onto the serosal surface as well. When cut open, the lumen was congested and contained creamy exudate, which is not uncommon. This is what we see. This is at high power. So this, I'll use the mouse so that people watching at home, this was originally the epithelium, and this has undergone almost total ulceration. We do see some epithelial cells there, but the vast majority of it has been replaced with this exudate, these inflammatory cells, fibrin, edemic fluid. There would be a fair bit of blood involved in that as well. And we can see here, even though the appendix is quite lymphatic under normal conditions, we can see that the lamina propria has undergone an edemic process, and also there's far more polymorphs there than would be otherwise. And this is something we can also see in the surrounding tissue. We can see the neutrophils adhering to the walls of the blood vessels, and you can actually see that quite clearly on the slides that you guys stained with CD45 last week. Some of you have got really nice pictures of your endothelial cells with all of these brown cells, almost the entire periphery of the blood vessel adhering, so that's pretty cool. You can see here too the difference in the neutrophil appearance to the lymphocytes that you'd see under normal conditions in the appendix. Cholecystitis. So again, we've got a blockage, in this instance of the cystic duct, by generally a gallstone, and that causes a build-up of bile in the gallbladder. The effects of concentrated bile pressure, and you can sometimes get bacterial infections as well, these all irritate the epithelium and damage the gallbladder wall. So it's basically what we saw with appendicitis, just in the gallbladder. We see inflammation, edema, swelling, and then obviously that can go on to rupture as well. About 90% of acute cholecystitis is from cystic duct blockage from gallstones. There are a few debates going on as to what causes these. It's thought birth control pills, pregnancies, there can be a genetic predisposition, obesity, diabetes, liver disease, or rapid weight loss is all thought to result in the formation of gallstones. You will cover, I think, gallstone analysis in ClinChem at some point, and you'll be able to break down into all the different types. It's basically precipitation of insoluble compounds or forming a stone. Cholecystitis can be tested for using ClinChem. Then you do an ultrasound. You might use that ultrasound to try and break down the stone, but generally that's not possible. So they'll remove the gallbladder. So our case study today is a 46-year-old woman. She had a history of recurrent attacks of pain, and so they removed the gallbladder. And you can generally feel the gallstones in there. Gallbladder's generally thicker than your thumb. It's got a very thin wall, maybe 3 or 4 mil max. When I say it's generally thicker than your thumb, bearing in mind I'm generally seeing ones that are inflamed. But you can palpate the stones, and the stones can be massive, and they can be quite, do I want to use the word pretty? I don't know. They can be multifaceted. They can look a bit like gemstones. Some of them can be translucent. They can have a really nice bile green to them, or they can be white and lumpy like these ones. So people have in the past requested their gallstones so they can make a necklace out of them. Whatever's at least they're not eating them. Oh, I'm sure there's some culture out there that would grind them down and sell them as medicinal. Again, with the gallbladder, at the neck, we've got a lymph node, so we need to assess that. There has been a very bizarre case of melanoma found in the gallbladder, so we need to look at these things. Then you'll basically just take a slice across the neck. That's one representative. You'll take a slice from the body and then a slice up at the fundus. That's it, 4 sections from a gallbladder, and from that you'll be able to discern whether or not that's an inflammatory process or something a little bit more sinister going on. So this is what we'll see, and these images, these were actually taken from your slides that you stained. Obviously this is H&E, but same section of the CD45. So we've got our mucosa here, which you can see at higher power, very congested, and obviously a large inflammatory response as well. We've got some exudate along the top there, so obviously that will build up within the lumen, build up pressure. You can also see often foamy macrophages in the gallbladder. These are cholesterol deposits within the cytoplasm of the macrophages, so this is from an overdose of lipids, probably hitting macas once or twice a week. So, but that's not uncommon. It's termed strawberry gallbladder from lipid deposits within the wall and within the macrophages as well. Pyelonephritis. So we're talking about inflammation of the kidney due to bacterial infections. When we talk about inflammation of the kidneys, there are 2 routes of inflammation. One is through the circulatory system, which will hit the glomeruli first. The other one is up the urinary tract, which will hit the tubules first. We're talking about up the urinary tract. So in that instance, we're typically talking about bowel flora, E. coli, Enterococcus. It's not uncommon in hospitals to see some form of UTI, generally accompanying with a catheterization, but obviously then you're looking at MRSA and all of those real fun ones. So, as always, it would start off as a lower urinary tract infection. And it's got to work its way through the bladder before it makes its way into the kidneys. There are some risk factors involved. Obviously, any mechanical defect that's going to prevent adequate drainage. So if you've got kidney stones or catheterization, as I've said, any stents or anything like that. Pregnancy is quite a nasty one because you end up distending and applying pressure where there perhaps shouldn't be pressures in the lower abdomen. So that can be an issue as well. And prostate disease. We talked a bit about prostate disease in the chute. How the donut becomes a bagel, so you can imagine how that will affect drainage. Diabetes, immunocompromised patients, obviously whenever we're talking about inflammation, if you're immunocompromised, you're already a bit behind the 8 ball. Behavioural changes, so changes in sexual partners within the last year, or spermicide use has been affiliated, so for uni students that first one's going to be a real bugger for you. And positive family history. So there seems to be some predisposition to colonisation, particularly around the urethra of certain bacteria within certain populations, so something to look into perhaps. We're looking at acute to begin with. So we've got a 43-year-old man. He was admitted to hospital. He was tired. Oh, sounds like me. Difficulty breathing. He was severely anemic. Maybe this is where we part ways. So he had a carcinoma of the cecum, so he already wasn't doing too well. He had blood transfusion. The cecal tumour was resected, and then 2 days post-operative, he developed an infection at the site of the catheter. It was a gram-negative, and in spite of a wide range of antibiotics, his condition deteriorated and he died 2 months later. Yeah, pretty unfortunate. So that at autopsy it was discovered that he had acute bacterial endocarditis, so that's probably what hit him on the head, but he also had acute pyelonephritis, which is fortunate for us because he donated his kidneys, or did he? Maybe we just took them. And now we can look at him as a case study. So the kidney weighed 460 grams, the cut surface showed a widening and pallor of the cortex, and then we've got a large increase in blood vessels and congestion within the medulla. This is just due to the inflammatory response. So this is what we see. Obviously, because we're coming up rather than down, the glomeruli are the last things to get hit, and they still appear relatively normal. Everything else, however, appears to be either inflamed or swollen from edema. We see a large inflammatory infiltrate radiating out often from the tubules, and yeah, the stroma is distended from edema. Again, it's fairly straightforward. You'd be able to recognise this tissue as kidney quite easily, and then you just look for the inflammatory cells, look for the swelling, the edema, and then work your way from there. You'd be then assessing, are the glomeruli primarily involved, or is it the surrounding tissue? If it's the surrounding tissue and the glomeruli appear unscathed, then it's likely to be a plionephritis rather than a glomerulonephritis. Chronic. This is quite, I won't say common, but it's not uncommon to have recurrent urinary tract infections resulting in a chronic plionephritis. So we've got a 26-year-old woman. She had frequent UTIs. Clinical and X-ray investigations suggested that there was some form of renal complications, so they removed one of the kidneys. Basically, you've got reflux in this instance of urine, and you've got chronic diabetes and dilation of the blood vessels, chronic movement of things either in or out of the blood vessels, and that actually results in scarring around the blood vessel walls, which you can see here. We'll look at fibrosis next week, but essentially you can see that the muscle coat of that blood vessel wall is massively hypertrophied, enlarged, increased, and even around that, the parenchyma, what would normally be normal kidney tissue, is largely collagen and fibrosis. There is a fairly defining characteristic of this condition, and that is these eosinophilic hyaline casts within the tubules. So this is basically concentration of that protein exudate. It stands out quite clearly, and if you see that sort of thing mixed in with the fibrous deposits around the blood vessels and that inflammatory response, more mononuclear in this instance because we're talking chronic, then that's generally what you're looking at. Foreign body granuloma. Do we have this as a case? Yeah, we do have this as a case study. So, I remember this one. Yeah, so 53-year-old male. I think I've mentioned this guy before. There was a palpable mass in the subcutaneous tissue. It was removed for histology because it appeared quite dark grey-blue, which is, you know, either a nevus of unknown significance or a melanoma. It was very palpable. Sent in for histology, and we're trying to cut it, and yeah, there was a piece of lead buckshot in there. But what you could see here is this massive fibrous response, and these giant cells. So these are the ones I was talking about last week. It's macrophages, mononuclear cells that have fused together and basically just patrol the periphery of the foreign body that can't be removed. So you'll be able to see that in the lab as well. This one we do not have in the lab, but I put it in there because it's something that comes up every year. I think I've got a student that will ask me about celiac disease. In this instance, the case study is a 5-year-old boy. It's not uncommon, particularly as the studies are becoming more and more accurate, for it to be picked up a lot earlier. He was presenting with anemia, lethargy, bloating, projectile vomiting, and an overall failure to thrive. Positive serology demonstrated the anti-tissue transglutaminase, not quite, but anyway, these antibodies that are against the glucose, what am I trying to say? The gluten, sorry, brain fart. So essentially it's immune mediated disease. It's not an autoimmune because the gluten is not endogenous, it's exogenous. But it triggers an immune response that kicks the body into overdrive. It's a genetically predisposed condition, and generally it's confirmed through biopsy of the small bowel. So we do see a lot of biopsies come through querying this, querying celiac disease, and this is generally what we'll see. So image A is normal and image B is celiac. So under normal conditions we've got those nice tall villi with nice epithelium goblet cells. The lamina propria is our loose connective tissue. We do see some leukocytes in there, but certainly not to the extent of an inflammatory response. And even the villi themselves stand up nice and tall. Whereas with celiac disease, because it's a chronic inflammatory response, we actually see removal of those villi, or villus atrophy. So you start to see basically the gut wall start to shrink down rather than having those nice tall towers, it just becomes quite flat. So obviously with your decreased surface area, that's when you start to see inability to absorb nutrients and diarrhea and all of those lovely things that coincide with celiacs. We also lose the brush border, so those microvilli, they're removed. So again, affecting our ability to adequately absorb nutrients from whatever it is we're eating. We do see some hyperplasia, but we won't worry too much about that today because we've not looked at cellular adaptation yet. But this is essentially what we're seeing here. So obviously if we remove the stimulus, we'll remove the inflammatory response, which is why these no gluten diets are so important. So that's it today. Again, another short lecture. But when you come into the lab, we'll have slides on all of these patients except for the celiac patient, and you'll be able to look at them. I know it's somewhat monotonous to be drawing again, but I do think it's the best way for you to internalise the structures that you're looking at so that you will be able to recognise them down the track. I've moved this away from a need for you to be able to identify, pleonephritis or cholecystitis, for instance. If you can say to me, this is appendix and it's undergoing acute inflammation, I'm sort of happy with that. As we move on, particularly for the mid-semester, I'll give you a bit of a pro forma as to what I want, because in the prac exam, rather than just saying, it's skin and I see simple stratified squamous, keratinized epithelium and hair follicles, I'll actually want you to just write a bit of a blurb. So, for instance, with the appendix, you would say, examination of the slide reveals acute inflammatory cells transmurally, so from the serosal surface to the mucosal surface, and you would say that the mucosa has been ulcerated, there's exudate within the lumen, this sort of thing. So you need to be able to start recognising what you're looking at and recognising these terms as well. But if you write down all of that and you don't write appendicitis, I'm not going to be too bent out of shape, because I really want you to understand the fundamentals of the pathways and how that applies to the body as a whole rather than specific organs. Because once you get out there, you're not going to be diagnosing these, but you are going to need to recognise these different pathogenic processes under the microscope to basically be able to quality control what you're doing and assist the pathologists to your full capabilities. And then obviously if you go into research as well, you'll need to recognise these structures. All right.